Good evening, everyone. This is Tanner with Equality Arizona, and this is Health is Queer Resistance. Katie Schneller and I started this project about a year and a half ago, and we were hoping to address the health needs in the LGBTQ community. We try to present both contemporary medicine and alternative medicine for people who are interested in those sort of things. And today we are joined by Gabriel Glissmeyer. Gabriel is a project specialist at the National LGBT Cancer Network and is based in Salt Lake City, Utah. His work focuses on LGBTQ tobacco initiatives and helping build and organize coalitions. For over 10 years, Gabriel has worked in tobacco prevention and cessation and LGBTQ exercise science. He received his bachelor's degree in exercise science from Augsburg University and is currently working on his master's of public health at Utah State University. Gabriel is passionate about LGBTQ health, reducing health disparities, and increasing scientific literacy. In his free time, Gabriel enjoys reading, cooking, and traveling. Gabriel Anashazi Jude that identifies as trans and queer. And I'd like to just welcome Katie and Gabe to the show, and I'm looking forward to this very important conversation.
Yeah, thanks so much for having me on here. I'm really excited.
Absolutely. Thank you. Michael said that you'd like to talk to our community about smoking cessation and about the risks of cancer. So I'll just turn the floor over to you.
Yeah, so I feel like a lot of the times when people think about LGBT health, the very first thing that comes to mind is usually HIV and AIDS. But what most people don't realize is that epidemiologically, tobacco and tobacco-related illnesses are actually the number one cause of death and morbidity and mortality in the LGBTQ community. And so that's a huge problem in the community, especially because people don't focus on tobacco a lot in our community. We don't get a lot of funding for tobacco in our communities as well. But it's still a huge burden in our communities. And we now have things like electronic cigarettes, which when they first came out were marketed as being safer alternatives to combustible cigarettes. And then those, of course, have their own health issues that come along with those. So we see a lot of health disparities, of course, with tobacco in LGBTQ communities, and then with cancer as well, just when it comes to having higher levels of discrimination and stress. And so usually with that means that smoking rates typically go up. And then you have trans populations that maybe don't feel safe going to healthcare facilities or don't have health insurance. And so we kind of see unreported incidences of cancer in those communities as well. So we kind of have this double-edged sword taking a really big toll on our community.
If you don't mind me asking, what comes to mind is, can you talk a little bit about why so many people in our community smoke? Could you be a little bit more specific about that?
Yeah, I feel like that's $1 million question. Why do people smoke? Especially now that it's not 1940, why do people still smoke? For the most part, it's been a long history of tobacco marketing specifically to the LGBTQ community. There's been incidences where the tobacco industry will sponsor pride festivals. They were known to do that back in the Castro district in San Francisco back in the 90s. So when they'd come out with a new product, they'd be like, hey, we want this to be the gay brand, so we're going to take it to Pride. We're going to hand it out for free. Problem is they're still doing very similar things now with electronic cigarettes. And so there's been a huge history of just really targeted marketing. Usually around Pride, if you open up a magazine like the Rolling Stones or Out magazine, you'll see a specifically branded Camel advertisement, or usually not Marlboro, but usually like Blue or Juul that has a rainbow on it. that it's like, oh, I know this is the LGBT, this is the queer advertisement that's meant for me. And so, yeah, there's just been a lot of that. So advertising, and then also just a lot of stigma and discrimination just when it comes to stress levels. I think one of the biggest misconceptions is that cigarettes and nicotine help to decrease stress, but usually they increase stress just physiologically. People report like, oh, just having that 5-minute break where I can just leave a stressful situation, go outside and smoke helps a lot. And it's like, I understand that does help a lot. And then you also have a community too where there's huge rampant mental health crises as well. And so just having that access once again becomes an issue where if you have to choose between paying out of pocket to go see a therapist versus buying a $15 pack of Marlboro, I mean, it's pretty obvious which one's not going to bankrupt you at that point. So there's a lot of issues that kind of keep people smoking.
What, if you don't mind me asking, why do you think that tobacco companies target the LGBT community? I mean, do they specifically do research on communities that have more susceptibility to stress? And do you know about that?
Yeah, so originally, and it's nice because back in the 90s, we had all the states sued the tobacco industries at the time. And basically, we had a flood of documents come out where we got to see all these really early PowerPoints. We got to see all these little memos, little Post-it notes. So once again, this is kind of a reminder: if you write something on a Post-it note and you work for a big company, it can be against you at some point. So be careful what you write down. So we got all of those things, and they did a lot of research where they would bring in typically gay men to look at different brands. To be like, hey, do you like this font better? Do you like this font better? And then they basically were trying to make a gay brand because they realized, hey, there's this population who doesn't have children, so they have a lot of disposable income. We want their money because they're not spending it on anything else. And so they really tried to find that gay brand. It took them a while. They definitely had some flops at the beginning where it just didn't meet what the community wanted. But now for the most part, if you ask people for a brand, usually it's either going to be Marlboro Reds, which are the most popular cigarettes in the world, or it's going to be some sort of mentholated mint cigarette.
So crazy. Thank you so much for this information so far. You clearly are super knowledgeable. Yeah. Before we got on this call, I was on the CDC and looking up some recent statistics, but they're not very focused, of course, in the LGBTQ population. But I was reading that since I think 2006, the percentage of people wanting to quit is at least significantly higher than those that are still smoking and not wanting to quit. But can you speak a little bit to the current stats, if you happen to know them off the top of your head or have something near? In LGBTQ population and kind of where we're at with our progress and whether people are wanting to quit or, wanting to kick this really obvious stereotype?
Yeah. And it's interesting that you asked that because we had a meeting about that this morning, and COVID actually kind of threw a wrench in all of this, as it did with everything.
Yeah.
And so they actually found there was a lot of misinformation at the beginning of COVID last year, where I think there was a French paper that came out that said, oh, we actually found that in our control group of smokers, they actually got COVID less than people who were non-smokers. So they're basically saying, oh, actually smoking is a protective factor for you getting COVID. So there was that huge thing that came out last, I think, April. It was like, okay, we don't need that type of information right now. And so they actually found that just because with people not being able to go to clinics, hospitals, things like that, community centers, people actually, I think it was 40% were less likely to quit last year. And so that's problematic when we know that COVID is primarily virus that affects the lungs. So we were like, okay, this once again is a problematic thing where we know that our community members aren't getting the help to be able to quit these products. And so, yeah, so that's one of the latest stats I think that we saw was that 40% were less likely to quit last year.
Wow. That's so interesting and also disappointing and sad. Do you think that well, actually, I would love to hear about what your organization is doing now to kind of fight against, I mean, not only just the smoking stats for the LGBTQ community, but also considering everything that's happened from COVID. Kind of what are some of the things that you guys are up to?
Yeah, it feels like we're up to a lot. Feels like we have our hands kind of everywhere all over the country. So a lot of stuff that we do with tobacco, we partner with a lot of states. We provide them with technical assistance. So whether that's doing LGBT terminology 101s or how to find an LGBTQ organization in your state, or how to build a partnership with them. We do a lot of that work, and helping them build coalitions where they make sure that there's LGBTQ people represented on their advisory boards, stuff like that. When it comes to cancer, we do a lot of trying to collect data because it's really hard to find, especially trans data, because a lot of people, for some odd reason, like to leave trans off of things. And so we try to collect that data as well. So right now we have our Out Cancer survey where we're trying to get as many people as we can who are LGBT cancer survivors to fill it out. And so we can kind of get a scope of, oh, these are the experiences of LGBT cancer survivors in the healthcare system in the United States. And it would be one of the largest, I think, LGBTQ cancer survivor surveys like in history. So it will be a big one. So we're really excited about that, and we're excited too to have a report after that of specifically Black and Brown LGBTQ people of color as well, because most likely we also have very separate health disparities, and so we're very excited about that. So we provide a education for the LGBTQ community on our increased risks for cancer. We advocate for cancer survivors, and then also just training healthcare providers as well.
That's great. Tanner, do you have something to say?
I was, being that you're talking about cancer, I think it's common knowledge that smoking commercial tobacco causes cancer. I'm curious if you can talk about the research that's been done on vaping and just on cancer and smoking and vaping in general.
Yeah, so vaping is a tough one, just because it's a relatively new product, even though it's been out for maybe like 10 years or so now, maybe a little bit over 10 years. I usually try to remind people like, when we had combustible cigarettes at first, it took us about 40 or so years before we were able to get really, really good data, just because it's more of longitudinal stuff that we're looking for. So as far as kind of, cancer, smoking, vaping, it usually depends on the community. So one really scary stat that we see a lot is that if you're Black and trans and you're a youth, you're 6 times more likely to vape. And then we know that with COVID, if you were a youth who ever had vaped before, you were 5 times more likely to be diagnosed with COVID. And so there's all these kind of fingers pointing that, vaping is not a protective thing. It's not helping anyone. And so kind of to answer your question, we're still kind of in the preliminary things, even though it's been a decade or more now. Hopefully we don't see things like cancer, but we really don't know, just because there's so many chemicals in these things that we know that they're not doing anything good. So that's kind of the only thing we can really say.
Do you know if there's, and I'm just curious about this as a person, do you know, like I know that commercially produced cigarettes are loaded with chemicals. So vaping, is it more chemicals? Is it less chemicals? Like what's the breakdown there if you know?
Yeah, so that's one of the really hard things to be able to even tell about them. It's because they're not FDA approved. None of them are. And so pretty much what you could do, like I could go on Amazon, I could buy the ingredients that I need, and then I could just make my own vape juice and I could sell it. And I could tell people, oh, it's organic. Oh, it's like homemade. Oh, it's all natural. And make a bunch of money off of that. And I would probably get in trouble, but not as much as these companies are. And so that's one of the really hard things is that all these companies, we don't know what they're putting in it because they don't have to disclose what they put into it because everything's proprietary. And so they don't have to list out all of their ingredients like the tobacco companies had to do with combustible cigarettes. So we really don't know like if the disposable ones, if those ones have less chemicals or more chemicals than the kind of modified ones that people make that are pretty big versus the ones that tobacco companies make. So we really have no idea. I mean, we know that for the most part, most of them have nicotine in them, which is not safe at any level. There's no safe level of nicotine. And so even ones, I know they've done tests where they'll take ones that have 0 milligrams of nicotine and they'll still find nicotine in them. And so there's just no way of knowing.
Wow, there's, of course, the issue. Sorry, Tanner. Yeah, I was just to jump in. Of course, the issue with vaping, which was that it was initially intended to help people with smoking cessation, to help them quit smoking. Right. And then people then instead have done both. They now are vaping as well as smoking cigarettes. So, you know, which is not the case for everyone, of course, right? That's a broad generalization. But there are some people that attempted to use vaping as a method of quitting smoking, and then they were unable to, and so now they do both.
So do we know if the cancer rates are higher in the LGBTQ community specifically because of smoking? And you know, I know that you came here with information to share with us, so at this point, you know, anything that you'd like to share with our audience would be wonderful.
Yeah, so once again, this is kind of one of those questions where it's like data, and the fact that we don't collect this data nationally becomes the issue where we really can't say for certain. So I know one of our estimates is that we believe that there's at least 1 million cancer survivors who identify as LGBTQ living in the United States, just based off of how many LGBTQ people identify that way in the United States, and then how many cancer survivors there roughly are in the United States. We kind of assume that there's 1 million. And then we kind of know based off of how many of us are in the country, and then how many of us or how many people smoke, we can kind of start coming up with a little bit of like estimations, but nothing really set in stone. Once again, it kind of, we assume that just with access to health insurance, healthcare, smoking rates, anything like that, kind of myths. I know the other week I heard an older lesbian say, oh, I don't need to get pap smears because I'm a lesbian. And I was like, nope, you need to get pap smears. And she was like, what? And it was like, yeah, you're not you're not in the clear yet until you meet this milestone, and then you can stop getting it. And she was like, I had no idea. And so, yeah, so there's a lot of misinformation of like, oh, I had like a double mastectomy. I don't need to like check for any lumps or anything like that. It's like, nope, you still got to check just a little bit, just in case something got left over. So yeah, so there's also just a lot of misinformation because we don't have enough research and data. So it's just this really terrible cyclical thing that feeds itself.
And the healthcare providers are uneducated. That's like one of the things that we first talked about. One of the first talks that we had is this whole health is queer resistance meeting when we first did it was wellness, just in general wellness tips, because there's so many things that people don't know, especially specifically the LGBTQ community. And one of those was lesbians think they don't need to get pap smears, and doctors don't even know whether lesbians need to get pap smears. And so it's a huge issue there. You briefly mentioned that you do some education for healthcare providers. Is that, I assume, just within the state, or what does that look like, and how's that gone?
Yeah, so we've kind of done it across the country, which is really cool. So pretty much any health system, any clinic can contact us and be like, hey, like, we don't know anything about this. Like, can you please help us? Or, hey, will you look at our patient registration forms, or look at our EMRs or EHRs or anything like that, and tell us if they're inclusive of your community. And we'll look at it and be like, oh, maybe you should add like what was your sex assigned at birth? Or maybe you should add more genders on there, or you should ask a sexual orientation question. So we do a lot of that stuff as well. Just like, here's how you can make your clinic, hospital, healthcare system a little more accepting. And so, yeah, or it's like, oh, if someone walks in and they need to get a pap smear done, do they have to walk into a women's center to get that done, where they don't identify as a woman? So we think a lot through those situations with healthcare providers as well.
That's really great.
Yeah.
So Gabe, what would you recommend for a person, maybe, you know, the person who picked up a pack of cigarettes again because they were bored at their home, you know, locked away during quarantine, and, you know, it was nice to smoke during that time, but maybe they're realizing, like, you know, I should probably quit this again, and maybe they want to like really quit this time. Yeah. What would you recommend to that person? What resources are available to them, and how would they go about it in a successful way?
Yeah, so I feel like the biggest thing is probably reminding them that on average, I think it takes about 6 to 8 times to successfully quit. So most people, like, usually when you hear that, like, oh, I stopped one day and I never picked it up again, those are pretty rare stories. So most people get really discouraged when they're on their 3rd time trying or their 5th time trying. So I usually just try to remind them it's a process, and it's going to be a lifelong process, just because nicotine is everywhere. And so it's always going to be kind of one of those things that pops up. I would probably tell them, like, hey, there's probably a quit line. If they're LGBTQ, most likely point them towards either a community organization, because most LGBT community organizations do have some sort of LGBT mental health services, which they also usually talk about cessation in that as well. The FDA, I think a few years ago, did their This Free Life campaign, which was super awesome, where they used drag queens and a bunch of interactive things to help people get ready to quit, make a plan to quit, stuff like that. And so that provided some tips of, like, oh, you smoked a lot of mentholated cigarettes, try like chewing gum that's also mentholated, and then cut back on your cigarettes. Or if you notice that you smoke when you go see your favorite band at a certain venue, maybe, like, I don't know, like, find alternative ways, essentially, of like picking up those patterns and being like, okay, I need to do the opposite of these things. So yeah, I'd probably just recommend those things to them. And then it's unique. I think everyone just thinks that there's just one way to quit. And every person that I've met has been a totally different way to quit. People come up with really creative things. And I have no idea how they come up with these creative things, but everyone is so unique, and everyone's quit story is also very unique.
I have a question for you. We have a large indigenous community in Arizona. I myself belong to a little tribe in Louisiana. I know that the rates of smoking in indigenous communities are pretty high. But I know that for myself, where I have fallen short on this issue myself is that there have been a number of times that I've quit using tobacco on a recreational basis, but then I go to ceremony and we use tobacco traditionally. And because of the way that I used it in the past, it's like, oh, here it is again. And so I was wondering if your organization has done any research on that, or if you have any words for indigenous communities.
So we haven't done specific indigenous First Nation research on kind of ceremonial tobacco versus commercial tobacco, because they're completely different things. I think a lot of people who aren't indigenous are like, oh, you can use them interchangeably. And it's like, these are very different things. So yeah, we haven't done any research on that. I don't know. I don't know if we would even be able to give any words of wisdom on that either. I think it's just kind of because it's such a spiritual thing. So yeah, I don't even feel like I would be able to provide anything about that. There are indigenous First Nation tobacco control networks out there who do specific education on kind of the differences and why indigenous First Nation communities smoke also at very high rates, and it also happens to fall very similarly to, oh, there was a lot of tobacco marketing to those communities, or there was a lot of tobacco representatives coming onto reservations and being like, hey, here's this like loose tobacco, you can use it in your ceremonies, or hey, you should pass this out to people. And so yeah, so unfortunately there's a huge history of that happening as well. But yeah, I would probably just say look into some of those First Nation indigenous tobacco networks.
Thank you. And I'm sorry if I threw you for a loop with that question. I just know that I always try to include our indigenous communities here in Arizona in our conversations because we're often underrepresented in these sort of conversations. But I just wanted to, you've come here and we're so grateful to have you here. Is there anything that you came to share with us that you would like our community to know?
Ooh, I feel like there could be so much. I guess it never hurts to get more education. I'd say that's the biggest thing. Of course, none of us know everything, and it's always good to continue growing. And I would say even for me, I've worked in tobacco prevention for so long. And it wasn't until this last year when I had a cancer scare that I was like, oh, there's these kind of barriers that even I have to getting this care. And I was like, this is really surprising because like I have this history in public health, but then I also have a history in clinical medicine. And I was like, oh, I'm able to talk this lingo. Like, I know how to like talk in the medical jargon to doctors, all these things. Like, I should be able to waltz in and be like, I need this, I need this, I need this. But even I was still running into these barriers. And, for me, it was like, okay, I'm this Black trans dude who's walking into the women's health center being like, hey, I need to get these surgeries. Can you do this? Like, I know I need this. I probably need it done like at this point. And even I still felt intimidated and like there was still something keeping me down. And so I think with that in mind, if I'm having that problem, I think that communities who have even less access won't even stand a chance. And so I think just being cognizant of that and doing what we can for the community and just getting education. So whether that's doing research on LGBTQ indigenous folks and getting that research on cancer rates or tobacco rates, that's really important. Or finding out how low socioeconomic status affects sexual orientation and gender identity when it comes to smoking. I think all of that's just really important to keep learning. And once again, I will say this: data is so important. And when we don't collect data, we don't do research on it, people don't really believe that there's a problem. And then it makes it really hard to pass policy to make health disparities go away. So, yeah.
So just that one thing you wanted to share.
I know, just that one thing.
Just one. Just education.
Yeah.
I know that you have had a meeting or have a meeting. Are you okay to talk for a few more minutes? Or do you need to go?
Yeah, I can talk for a couple more minutes. Yeah.
Okay, great. I think we would love to know sort of how you personally came to this field and this career, and do you love it? Do you hate it? You know, maybe a little bit just an insider, you know, on how you feel and what you think.
Yeah. So I originally, I know, because it's wild, because then when I tell people like, oh, I've been doing this for 13 years, they're like counting on their fingers and they're looking at me and they're like, how old is this guy?
Mm-hmm.
So I actually started when I was 14. And at the time, I know, very young. And at the time, I had a sister who was going through a substance use disorder, and she was also smoking. And I was trying to figure out a way to come up with resources for her. And I found this youth advocacy group, and I was like, sure, I'll join. And so I just loved it. And as I was going through it, I was like, yeah, but I'm not seeing myself represented in this. So there has to be numbers on this. So I got really big into LGBTQ health from there. So I stayed in kind of tobacco prevention for a really long time. And then I got equally as interested in clinical medicine. So I got my medical assisting license, started working up in colorectal surgery for a while, which was a blast to say the least. And then I kind of just bounced around between areas where we just didn't have a lot of data. So I focused a lot in my undergrad on trans communities and exercise physiology, which then became pertinent this year, where there's all of these anti-trans bills that have been popping up across the states. And then I kind of dabbled in pharmaceutical research for a little bit, and then kind of settled back down now in public health. But I feel like it's been great just because it just impacts so much. I feel like there's always something to learn. There's always policies that need to be made. So it's been a really nice, I would say, welcoming back now fully to public health. So it's been a wild ride.
That is a really awesome journey. And yeah, you came like full circle. You started here, I'm going to follow the train, and then right back. Mm-hmm. That's so great. That's so interesting. Do you think that you'll stay in this career now? Like, are you fully satisfied with where you are and love what you're doing and find it fulfilling, all of the things?
Yep. Yeah. Sometimes I dabble with like, oh, maybe I'll go and get my MD, PhD together. And I'm like, I don't want to do more school. Like, no. So, but I don't know. I dabble with that idea a little bit. And I'm like, I feel like my partner would not like that. He'd be like, nope, that's too much time. So, yeah.
Tanner can talk to you all about being in school, and I can too. I'm done, thank goodness.
Right.
But Tanner's still in it. Yeah.
It is a lot to manage school and work and everything else. And good luck with you're in a graduate program now, correct?
I am. Yep. I'm a couple of semesters away from being done.
Woo.
Wow. Well, yeah. Congratulations. And
thank you.
I personally know how hard that is because I'm doing it myself at the moment. So
right.
But thank you so much for joining us. I know that you have to get on another call, but we're just really grateful. We're grateful to all the guests who come on this program, and it's just and you brought with you not only wonderful information but a really good spirit, and I really appreciate that. You know, it's just even over Zoom when someone comes on with a big energy and a nice smile, it feels good. So thank you very much for coming here that way.
Thank you, Tanner. And thank you so much, Dr. Steller. It was so nice meeting both of you and being able to talk about
nice to meet you.
all of this stuff. We just barely scratched the surface, but there's more to talk about.
Yeah, tobacco, LGBTQ health forever. If we want to stalk each other on Instagram or get more information, though, too, from the company that you work for, what is some contact information that we could include in like because we can do that, right, Tanner? We could put it in a comment or something on the live stream, or
correct. And we've already put a link to Gabe at the Cancer Network, and we put a link to cancernetwork.org. And if you have any other links that you'd like to share with us, we would be happy to share it with our audience.
Yeah, those ones are great, especially the one with mine, just I think it has my email on there. And so if people have cancer stories that they want to share, or stories about how they've been impacted by tobacco or vaping, they can definitely email me, because we're collecting those stories as well. So that's definitely, those are two great links.
Awesome. Well, thank you for joining us very much.
Thank you. And I hope you both have a good rest of your night.
Thank you. You too.
Thank you so much.
Okay. Bye.
Bye, Gabe.
Bye. Well, that was awesome.
Yeah, so full of information, and it's so funny that you said that about his energy, and he's like, he came on with this big smile, and I enjoyed his presence and his information a lot.
Yeah, it's really good. I'm curious if, I'd like to continue talking a little bit about this issue, and from a naturopathic perspective, I'm curious how you treat smoking. And what you, I know that a lot of I'm fortunate right now because I'm in graduate school, I have health insurance. So if I wanted to take a conventional medical route, that's available to me. But so many people, especially people who might be out of work, may not have access to medical treatment right now, and may be trying to kick the habit. So I'm just curious if you could talk about some ways that people might be able to use on their own at home, or nutritional things that we could mention.
Yeah. So like Gabe mentioned, everything is really person dependent. So each person's journey is, going to be very individual. And that's part of naturopathic medicine, is treating everyone in their specific case. And so really the way that I have to come at it with my patients that are very sure that they want to quit, that's part of it, right? I go into a pretty in-depth questionnaire about why you want to quit, and how you think it's going to make you feel, and what it's going to take in order for you to do that, and what your obstacles are going to be, and how much on a scale of 10, do you want to stop using tobacco. And once we kind of establish a baseline and you get the mental piece there, then we can implement other things. Because if I give you a supplement, or we do acupuncture, which there are, proven acupuncture protocols, particularly in the ears, for nicotine withdrawal and for smoking cessation, we can do that all day. But ultimately, if you're not in a place where you truly want to quit, then it's kind of futile to do anything like that. So a few things that I've found have been effective, and studies have shown also to be effective, are some kind of really simple lifestyle habits. One of my favorites can go with any habit that you don't want to do anymore. So, if you have, let's say you have you overeat or something like that. If you're consistently overeating, or we'll use the smoking example, right? That's what we're talking about. If you smoke with your right hand and you want to quit, start picking up cigarettes and smoking with your left hand. And literally just using a different side of your brain will engage it and say, hey, I don't want to be doing this because it feels weird, because it's not the way that I'm used to smoking. It's like the opposite of the habit. And so sometimes that can help. Really simple things like that. And just keeping in mind a specific date that you'd like to quit by. Usually about 3 to 6 months out is kind of a good standard. Like, okay, by, what is March? So, by Halloween, I am going to quit smoking. I'm going to have my last cigarette on Halloween night, and then I'm going to be done. And up until then, I'm going to continue decreasing, weaning off of smoking, because that has been shown to be more effective than quitting cold turkey. But like Gabe mentioned, um, uh, it quitting cold turkey is pretty rare. So, but it has worked for some people. One other thing that I do with my patients is I use a dependence scale for nicotine. So you can find the PDF online. You just search nicotine dependence scale, and it's basically grades it, and it lets you know whether you have a mild, a moderate, or a severe dependence on alcohol, or on smoking, on nicotine. So just a few things like that. And if you want like specific herbs and that sort of thing, 5-HTP, the precursor to serotonin, can be helpful before meals. It helps to release the same stuff that nicotine releases, so dopamine, norepinephrine, GABA, glutamate, other endorphins. And then there are a few herbal products that I know of offhand. One is by Wise Woman Herbals, and it's called Smokeless. And then another herb is called kudzu. It's Kudzu. And then ease strain. But of course, if you're doing any of that, talk to your doctor, talk to your naturopath in order to, get dosing specifications and all of that. So hopefully that was a comprehensive answer.
You said 5-HTP, and what was the one that you said after that?
What did I say after 5-HTP?
Was it kudzu?
Wise Woman. Oh, kudzu. And then Wise Woman Herbal is it's an herbal company, and the product is called Smokeless.
Okay. Thank you for sharing that with us.
Sure. Yeah.
I'll maybe ask you one more question, and then Jean's going to jump on to talk about give a policy update. I'm curious about, I've had success in my life with quitting things and with making lifestyle changes by changing my diet and my nutritional intake, supplements. And you mentioned some specific supplements that people could take. Are there vitamins that people could take? Are there specific vitamins that are useful, like vitamin C, or thing, like, let's say that you're just in a position where you're just like, I'm not kicking this habit, and I want to stay alive anyway. So like, are there some like anti-free radicals that people could take? Or I don't know all the terminology, but like, if you could just talk to us about that.
Sure. So as far as I'm aware, there's not a specific like vitamin C, vitamin A, that sort of thing that helps. There's of course a ton of stuff that helps boost the immune system. Vitamin C, zinc, right? And smoking decreases the immune system, but nothing specific to the nicotine tolerance necessarily. But one of the best things to take for free radical scavenging, basically. So everything that the free radicals that we get in our body from the poor air quality, from stuff in our food, from smoking cigarettes, other chemical or toxic exposures, our body produces something called glutathione. And so when the body produces glutathione, it is an antioxidant, goes around and eats up the free radicals so that they can be eliminated. So there are glutathione products. Doctors can prescribe glutathione nebulizers, and so you can inhale it with like it looks like a mask, and then you can also take glutathione orally in a capsule. That's helpful too. And there are injectable forms of glutathione. The only thing with the injectable forms is that they have a significantly shorter half-life, so their effectiveness lasts longer, but they're really strong, much stronger in a few minutes than an oral form or a nebulized form could be. So I would say glutathione is the most potent thing, but I'm not sure if there's any specific research behind glutathione and nicotine, but as far as free radicals goes, glutathione's great with that.
Thank you for sharing that. And now Jean's going to join us and give a policy update. We've had a lot of anti-trans bills and just problematic legislation in Arizona in general. And so thank you for joining us, Jean.
Yeah, thanks. I've been really enjoying the conversation so far. Gabe was super cool. So I want to tell a story that I think is kind of one cohesive story about two pretty separate and extremely dissimilar policies, both of which had pretty significant hearings yesterday. So yesterday morning, the Senate Judiciary Committee held a hearing on the Equality Act, which has passed the House and is now in the Senate. And the Equality Act is kind of a broad non-discrimination protection that includes gender identity, sexual orientation, for a lot of categories. So we had the Supreme Court decision, Bostock versus Clayton County, which extended some of those protections in certain cases. And this is a more broad application of that concept, that sex discrimination includes gender identity, sexual orientation. So yesterday was that hearing, and I think this ties into something Gabe was talking about, which I would love to talk to him more about this data that he was studying. But these policies, the Equality Act, things that we're seeing here, non-discrimination ordinances in Mesa and Scottsdale, they're fundamentally not about trans kids in sports. That's not why they're written, but it's something that's being leveraged as a way to, create like a fear campaign around these bills that, versions of them have existed in cities and states across the country and just generally improve people's lives and haven't created any of the issues that are sort of featured in these fantasies of fear. But something that comes up a lot as their wedge issue is those student athletes. I want to pivot to sort of like a broader issue, which is that they take, okay, here's the specter of trans identity, and they say this is a threat to a number of things. So the athlete scare is, okay, they're saying it's a threat to women and girls, which it's not. And it's also like a parallel to that, they use religious freedom, right? So they talk about how religious institutions and organizations are classified, and they say, okay, but then someone's going to come along and say, well, but, and they phrase it in this way where they say, here's something that no one's ever heard of before, trans people, and how could they ever know what to do with this, right? And so Tom Cotton, who's on the Senate Judiciary Committee, phrased this, and I think a lot of these hypotheticals, what I'm trying to say is they don't play out in the real world, but the way they're structured is specific and interesting to examine. So Tom Cotton's hypothetical was effectively, let's look at a religious charity that serves people with Down syndrome. And in his hypothetical, this charity is operating for years and years, making people's lives better. And then along comes the trans lobby or whatever it is, and they say, but you don't use gender inclusive language. Therefore, you have, violated these new rules, and somehow the existence of trans people is going to threaten charities that serve disabled people. Tom Cotton used a really specific phrase, which is then the pivot into another policy I want to talk about, which is he was talking about this hypothetical charity to serve people with Down syndrome. And he said, to show them that they are fearfully and wonderfully made, which is a quote from the Bible that's really popular with anti-abortion groups and has been kind of popular for a long time with them. And this hypothetical is interesting in this context because it's in this whole category of the trans specter. Here's the whole threat that trans people pose to ordinary people's lives, whatever that's supposed to mean. And he's using something that's really, really out of the playbook of anti-abortion groups, which is talking about people with Down syndrome. And then this phrase, which I think is the kind of real tell, fearfully and wonderfully made. Over the past decade, a lot of anti-abortion groups have really gravitated towards this fixation on people with Down syndrome because there is a real statistical difference in the rate at which fetuses that test for chromosomal abnormalities like Down syndrome are, those pregnancies are terminated. There's a statistical difference. And so anti-abortion groups have kind of capitalized on that to phrase it as sort of like a wedge issue, which is the main anti-abortion rhetorical strategy. They give you something like, well, what about this situation where you might have to stop and think because you haven't thought about it before? And then they say, well, if you have reservations about terminating a pregnancy in this situation, what's different about any other situation? And so we've seen that with sex selective, race selective abortion laws in Arizona. And these are things that on the face of it, you say, well, right, these are forms of discrimination, right? That's how you think about it, maybe. Or you think, well, maybe that's rooted in a sexist or a racist position, right? That doesn't really apply to abortion, but that's how they get it in the conversation. And what they use these real issues for is to sneak in new restrictions on abortion. So there's a bill right now in Arizona, SB 1457, which takes this kind of, and I think it's important to say that this is appropriation, right? They take the idea of genetic difference, which is how they phrase it in, or genetic abnormalities, which is how they phrase it in the bill. And they use this to say, here's how we are going to limit other people's lives, right? Here's how we're going to limit access to healthcare. They're not writing bills that improve the lives of people with genetic abnormalities. They're writing bills that take the fact of those people's lives and use it as a weapon or a cudgel to restrict people's rights. So SB 1457 had a hearing yesterday in the House in Arizona that they just kind of rammed it through. The idea was people would be able to give testimony. This is how things normally work. And the way it went in this hearing, they completely limited testimony and even different legislators' ability to speak on this bill. To talk a little bit about the content of the bill, SB 1457, like I said, takes existing penalties for performing abortions that apply for like sex selective and race selective abortions and apply it to abortions based on genetic screening. This is something that says, okay, if you perform an abortion for these various reasons, there's a class 3 felony applied to that, which is pretty severe. And then another part of the bill, which really goes undiscussed and has nothing to do with genetic abnormality, is there's a set of restrictions around what public educational institutions can do in regards to abortion. So they can't refer for abortions and a number of other things like that, which this includes public schools, charter schools, community colleges, state universities. So not only does this compromise like the health of a huge, number of people in Arizona, but it also compromises like the academic integrity of like our state medical schools, right? So really bad bill. And yeah, I think I'm going to wrap it there. Because I've been monologuing for like 10 minutes straight.
Thank you so much for sharing that information with us. And what was occurring to me while you were speaking, maybe you could just answer this before we get off the call. Let's say you're listening to this program and you're a cis member of the LGBTQ community. You identify as gay or lesbian, and you don't really necessarily know a whole lot of trans people. And you want to understand why it's important to support these bills, but you don't quite get it. You know what I mean? Like, can you explain how supporting trans rights right now is vital to the entire movement and how it affects the LGB community?
Yeah, I think that's a great question. And really it ties into kind of what I was talking about. All of this occurs within like a broad rhetorical strategy by like the reactionary right to, in the case of these abortion bills, appropriate the lives of marginalized people as a cudgel against other marginalized people, or to create like a moral panic around certain identities. So if you want to know why this applies to you as a cis LGBT person, right? All you need to do is take 5 minutes and watch Abigail Shrier in the Senate Judiciary Committee hearing yesterday for the Equality Act talk about her idea of what the threat of trans people is. And if you just kind of search and replace, trans and whatever your identity is that there has been a moral panic around, it's exactly the same. So everything that I heard growing up in the 2000s, in the Bush era, right? It's just exactly the same, kind of word for word. She talks about like eating disorders and demonic possession and kind of, like witchcraft. It's exactly the same moral panic that gets applied to apparently everyone in their turn. Right now it's trans people, but it's the same strategy that's hurt every queer person at some point in their lives. So that's why it matters.
That's so amazing, Gene. And what I want to really thank you for is explaining the rhetorical strategy that's being used. And just to, for people who might not be familiar with that term, the way that I understand it, it's just basically the way that Republicans are framing their argument. They're framing the argument to create fear, and we never know what parts of our community's rights to live that they plan to go after. And we don't. And I'm sure that there are people who understand the larger political agendas at play, but what they're doing is not working in our favor. And I really appreciate you understanding that, because I feel like the right does a really good job at explaining the rhetorical strategies that the left uses, but we don't always on the left do the same for our communities to kind of like understand what's really happening in their arguments. So Thank you for sharing that with us. It's really scary and really informative. And Katie, it's good to see you again.
Good to see you too.
Yeah, it's really nice. It makes me feel good to be here. And to everyone out in our audience, I want to say thank you for joining us. This Saturday, March 20th at 6 p.m., we are going to have another queer poetry salon with the Piper Center. I'm really excited about this reading. It's featuring one of my teachers, Ariana Rains, and a person who's originally from Casa Grande, Eduardo Sicarao, and then the poet Golden is going to close out the evening. So please join us for that. And please make sure to look up the Equality Arizona podcast. We do some amazing political education work with Dr. Kwan from ASU, who's a political theorist. And then we also have a queer and trans cultural hub wherein we talk to artists, poets, visionaries in Arizona and beyond. So please join us for all those things. Please continue to watch our live streams, and we are grateful that you watched this evening. Thank you so much.